Hello, welcome to an introduction to aging and dementia, where we will discuss the background of healthy aging and the signs and symptoms of dementia. In this module, you will learn the terms used when discussing the aging process. We will also categorize how dementia is different from the path of healthy aging. There are small differences in healthy aging, mild cognitive impairment, and dementia. We will discuss how to recognize these changes in your patients. We will describe the natural history of dementia, and we will discuss how to identify some common signs and symptoms. We will outline the physical, emotional, and economic impacts of dementia. Lastly, we will tell you what you can do to help prevent dementia and discuss the need for further research into this condition. This class has been specially designed for those who work directly with patients as community health workers. You are an important link between the patient's family or caregivers, and the physician. Physicians rely on community health workers for important information and observations that may not be seen during routine medical appointments. Patients and families depend on you to make sense of the medical information communicated by physicians about dementia and other diseases. This module will provide current information about dementia. You do not need to have any prior knowledge of this subject. You will learn about keeping your older patients healthy and about recognizing the signs and symptoms when something is wrong. Let's first begin the discussion with a real-life scenario. Meet Mrs. Reyes. She is a 79-year-old widowed mother of 3 who lives alone, but luckily she's only down the street from one of her children. Her family is concerned because she does not leave the house as much as she used to and has had some new memory problems. She has trouble remembering appointments and important events, even when reminded constantly. She has difficulty following conversations and repeats herself often. She gets frustrated when her children remind her about things and feels they do not respect her. At home, there's a stack of mail next to the door with unopened letters from 5 months ago, including a late bill. Fortunately, her daughter found the bill and paid it on time. Mrs. Reyes says it's just her age catching up with her. Her family is wondering if she is right or if they should be worried about something more. How would you respond to Mrs. Reyes' children? Would you tell them that her symptoms are normal for someone who is getting older, or should they worry about something more? Does she have dementia? How would you decide? We will come back to this case to illustrate some important points. First, let's start by defining a few new terms: memory and cognition. We probably all understand memory as basically the storage and retrieval of information. You may have a good memory from a special event 1 year ago or stretching from 10 or more years ago. The term cognition is more complex. It is a broader term that includes memory and also mental abilities and functions, such as how you acquire new knowledge and how you understand the world around you, through experiences, through your senses, and by your connection to other thoughts. The term dementia is an umbrella term for a group of disorders that describes advanced cognitive impairment, which is not considered a normal aspect of aging. We will use the term impairment throughout this module. Impairment is a medical term that means something is now weakened or damaged from its original healthy state. In addition to affecting your memory, dementia can interfere with orientation, learning of new information, such as how to use a new TV remote control, how you understand language, such as finding the right word to say, and judgment, such as finding out how you will get ready for the day. It is important to note the memory loss in dementia is usually short-term memory loss, or the ability to remember newly learned information. Often, long-term memory, or memory of early life events and relationships, is preserved until the individual reaches an advanced stage of dementia. To help us understand the differences between dementia and the normal progress of aging, experts may place the progression into groups: age-associated memory impairment, mild cognitive impairment, and dementia. Age-associated memory impairment is the normal range of changes in cognition and behavior by someone in older age. This includes things like occasionally misplacing keys or taking a little longer to make calculations while at the grocery store. However, in normal aging, individuals will be able to retrace their steps to find their keys, and they'll eventually come up with the correct answer to their calculation. Cognitive impairment that does not cause problems in a person's ability to live an independent life is called mild cognitive impairment. People with mild cognitive impairment have problems with memory or other cognitive areas, but are still able to lead an independent life. About 7 out of 10 of these individuals will go on to develop dementia. Dementia, also called major neurocognitive disorder, is described as advanced cognitive impairment. It is gradual, disabling, and causes enough problems for the individual that they no longer are able to carry out an independent life, to perform activities of daily living, or to care for themselves. Though we have learned a lot about this disease, it remains to be a puzzling disease that is difficult to put together. What is understood is that dementia is caused by a deterioration of the brain. Cells lose their ability to communicate with each other and to function normally. There are as many types of dementia as there are symptoms that describe the disease. Remember that dementia is an umbrella term that describes a group of disorders. All the types of dementia are related by the fact that changes happen to the brain's chemistry, causing memory loss and confusion. However, each type of dementia has a unique pattern of symptoms. Keep in mind that it is common for many people with dementia to have brain changes that are associated with one or more types of dementia. We call this overlap mixed dementia. For example, some individuals may have a mix of Alzheimer's and vascular dementia. Alzheimer's disease, also known as Alzheimer's dementia, is the most common and makes up for anywhere between 60 to 80% of cases. Typically, Alzheimer's dementia starts with short-term memory problems and progresses over 8 to 12 years to include problems with judgment, problem-solving, organization, and later, problems with language. We also find that anxiety and depression often coexist in people with Alzheimer's dementia. Vascular dementia is caused by cholesterol plaque buildup and other changes in the brain's blood vessels that reduce the blood and oxygen flow to the brain. This may occur slowly over time or may happen through major life events such as strokes. Typically, vascular dementia causes a larger impact on judgment, problem-solving, spatial awareness, and muscle function or mobility. Vascular dementia typically gets worse over time unless risk factors are addressed. Frontotemporal dementia uniquely affects the population under 65. This type of dementia may cause changes in personality and in behavior. Lewy body dementia causes symptoms similar to Alzheimer's disease, but is unique because it begins with sleep disturbances, hallucinations, and impaired muscle function very early in the disease. Alcohol-related dementia is a less common cause of dementia, but may occur in those that have used alcohol excessively for many years. The brain changes that occur as a result of alcohol use may be reversible or permanent depending on the extent of the damage. When talking about the signs and symptoms of dementia, we should keep in mind that memory and cognitive impairment are intertwined, and that there is a natural progression of decline in brain function with age. What makes dementia different is that, as noted in a previous slide, the loss of function of the brain due to dementia causes an inability to perform everyday activities, such as paying bills, driving, preparing meals, and later, it becomes difficult to bathe independently and to use the restroom, to dress, to walk, or to eat. In cases of dementia, we may see signs in individuals who lose their possessions frequently, have memory problems, and have trouble communicating, as well as loss of motor function, which leads to their loss of living an independent life and their ability to perform tasks. As a community health worker, watch for these changes in cognition, memory and learning, language, executive functioning. This means the person's judgment and ability to make complex decisions, how the person understands directions while driving, complex attention, and lastly, is the person acting out of character, or are they appropriate for the situation? Exactly how common is dementia? Historically, dementia has been underdiagnosed, meaning the signs and symptoms often go undetected. Many individuals who would meet the criteria defined by a physician for Alzheimer's and other dementias are not diagnosed because they lack access to a provider who can make the diagnosis, such as a primary care doctor, a geriatrician, or a neurologist. Even when a diagnosis is made, it's possible that a patient is not aware of the diagnosis due to poor communication between the provider and patient. This highlights the important role the community health worker has to bridge the gap between the provider and the patient. As of 2018, there are 50 million people globally with dementia, and that number is expected to triple by 2050. In the U.S. alone, it is estimated that 6 million people are living with dementia, and this is also expected to increase, with a large number of people growing to age 65 and older. Though both men and women have an increased risk after reaching the age of 65, this risk doubles every 5 years, and it is reported that women are more commonly affected. According to the Alzheimer's Association, Latinos are at increased risk for developing dementia when compared with non-Latinos due to risk factors such as high blood pressure, high cholesterol, diabetes, and lower education level. Furthermore, Latinos are less likely to have access to care to reduce these factors. It makes it more difficult when a diagnosis of dementia is finally received due to possible language barriers, lack of insurance coverage, and difficulty getting in to see a provider. Alzheimer's disease makes up 60 to 80% of all dementia cases. These are more recent numbers. Alzheimer's disease makes up 60 to 80% of all dementia cases. These more recent numbers reflect a jump in diagnosed cases and also point toward a growing awareness of the disease. Here are the numbers in the U.S. 10% of the population aged 65 and older have Alzheimer's disease. Over 80% are aged 75 and older. Alzheimer's affects more women than men. 13% of Latinos aged 65 and older are thought to have Alzheimer's or a related dementia. Increasing age is an important risk factor in developing dementia. As noted previously, as of 2019, it is estimated that 5.8 million Americans live with Alzheimer's dementia. From this graph, we can see that the percentage of people with Alzheimer's dementia increases with age. Of the 5.8 million people, 4.7 million are 75 and older, and 5.6 million are age 65 and older. These are 2019 graphs, representing estimates of the number and percentage increase of people aged 65 and older with Alzheimer's dementia by state. Every state is expected to see an increase of at least 12% in the next 15 years. States in the West and Southwest, including parts of Texas, are expected to have the highest percentages. In 2015, the entire globe spent $818 billion on medical and social care programs for patients with dementia. In the U.S., while Medicare, Medicaid, and private insurance pay for most of this care, families and caregivers are left to pay the rest of the $230 billion bill. Although this number seems very large, it still does not account for the many unbilled hours of caregiving from family members and caregivers. As of 2018, Texas reportedly has about 1,500 caregivers that spent over 1.5 million hours in unpaid care. This amount of unpaid care was valued at over $20 million. According to a study done by Wemo and colleagues in 2013, for older people, dementia is the leading chronic disease causing disability and the need for personal care services. As the disease progresses, patients often lose their sense of self and slowly give up their independent lifestyles. With this loss of independence, patients feel the direct emotional impact of dementia. Changes in mood and behavior are common, such as depression, indifference, or loss of motivation, loss of excitement, increase in anxiety, panic, agitation, and even aggression. Changes in personality may occur, such as being suspicious, paranoid, and fearful. This may lead to patients becoming easily upset and may cause stressful interactions that can impact close relationships. Finally, some may experience social isolation by their withdrawal from work or social activities. As a result of the increased disability caused by dementia, caregivers play an essential role in assisting patients with dementia to take care of their activities of daily living. Caregivers may be paid or unpaid and may or may not be a family member of the patient. While gratifying work, caregivers join the journey along with the patient and find their own physical, mental, and emotional health being taxed and stretched to the limit. Caregivers are vital in the role they play in patients' lives, but it can take a toll on them too. It is reported that nearly half of caregivers suffer distress, especially depression, and decline in physical health. In fact, 35% of caregivers state that their health was worse as a result of caregiving. This is in part because stress levels are high when caregiving for a patient with dementia. Before reaching a point of burnout, caregivers are encouraged to seek help with a therapist or psychiatrist who is familiar with caregiver challenges. Seek help from the patient's healthcare providers to identify resources and support. Self-monitor for signs of burnout and depression, and keep an eye out for these signs and conditions in other members of the patient's care team. Lean on friends, family, online communities, support groups, and houses of faith. If caregivers do not attend to their own health and well-being, it can translate to less than average care for the patient. Or even worse, caregivers who do not take care of themselves are at increased risk of unintentional elder abuse and mistreatment. As noted previously, Alzheimer's dementia accounts for around 60 to 80% of all dementia in people 65 and older. We have seen that some risk factors for Alzheimer's dementia are age, ethnicity, and gender. Remember, too, that our current knowledge on Alzheimer's dementia leads us to believe that women and Latino and Black groups are at a higher risk. But we should also note that dementia has a family history component. Dementia often goes underdiagnosed, so a family history of memory problems, even without a dementia diagnosis, may be important. Studies suggest that nearly half of people who have a first-degree relative with Alzheimer's dementia develop the disease themselves by the time they reach 90. Certain histories of medical conditions may be risk factors that we should highlight, such as cerebrovascular disease and stroke, diabetes, high blood pressure, high cholesterol, hearing loss. How can you remember things you never heard in the first place? There are other risk factors that may play a role in developing dementia. some of which can be prevented or managed to reduce risk. These include lifestyle and physical environmental factors. For example, diets high in fats, carbohydrates, simple sugars, or diets low in fruits and vegetables may contribute to poor health, and this may be a risk factor. We know that heavy alcohol or drug use has shown to be a risk factor. Use of certain high-risk medications such as opioid pain medications, anxiety medications, and sleep aids may also be a risk factor. Adults who have a lack of physical activity may place themselves at greater risk. Doctors recommend a total of 150 minutes of activity every week. That is approximately 20 minutes per day of exercise. Just as our bodies need exercise, our brains need exercise too. Socializing with friends, family, or in positive social settings is good for our brains and is also good for our psychological well-being. On the topic of well-being, certain behavioral health conditions can mimic dementia or even contribute to cognitive impairment. These include major depressive disorder, post-traumatic stress disorder, PTSD, sleep disorders such as sleep apnea. These are conditions which require treatment from a qualified health professional, just as any other disease. In certain cases, head trauma, seizure disorder, and certain autoimmune diseases, such as rheumatoid arthritis and lupus, have shown to be risk factors. There may be a way to protect ourselves and encourage our patients to reduce their risk of developing dementia. These include engaging your brain in stimulating activities, increasing physical activities, and lowering your blood pressure. The basic idea is that through a change in diet, an increase in exercise, making lifestyle changes such as quitting smoking and drinking, we may bring about better overall outcomes for our patients. These changes may come by way of lifestyle interventions geared toward health, such as a walking club, or by improving cognitive functioning, such as community support groups. This requires using cognitive abilities and helps engage people in their own health. Research suggests that cognitive training and increased physical activity can delay or slow a decreased cognitive function. Blood pressure management in patients with high blood pressure is a powerful tool and is thought to be able to prevent, delay, or slow dementia. There is an urgent need to understand dementia and to know how to prevent and treat the disease and help people live longer, healthier lives. Researchers are hard at work, yet still have more work remaining. This video from the National Institute on Aging shows the importance of this work.
People are living much longer, and a common consequence of aging is loss of thinking skills. There's no clear line between what's sort of normal loss of thinking skills and disease. Being able to systematically study that makes it a little bit more challenging.
There's a great amount of noise, a great amount of misunderstanding out in the world about what the causes are of dementia, and more importantly, what you can do to prevent it.
In 2015, 4 to 5 million adults in the United States were suffering from dementia, costing more than $200 billion. As the population grows and people live longer, the number of people with dementia will increase.
When people become impaired, it doesn't just affect them, it affects everybody around them. Their families have to take care of them. This has enormous effects on the whole society in ways that lots of other diseases don't.
The National Institute on Aging at NIH asked the national academies to convene a committee of experts to evaluate the latest research on how to protect cognitive health. The committee looked at studies on 3 types of conditions: age-related cognitive decline, which can be a normal part of aging; mild cognitive impairment, in which a person shows more notable problems but can adapt and live independently; and clinical Alzheimer's type dementia, in which someone can no longer function independently. This includes Alzheimer's disease, which is the leading cause of dementia, and other diseases with similar symptoms.
When people are developing mild problems, we ask about things like how often they're forgetting appointments, how often they're misplacing things, how often they're having trouble paying their bills. When a disease progresses to the point where someone has dementia, then the forgetting is not mild like that anymore. Then people have trouble remembering something from minute to minute, and sometimes from second to second.
Cognitive decline and dementia progress slowly, and damage in the brain often begins a decade or more before any symptoms show up. For a while, the brain can adapt, which can mask the early stages of the disease. But by the time someone starts exhibiting symptoms, damage in the brain could be extensive.
So long before someone has trouble remembering names, getting lost driving in a car, there will have been detectable changes in the brain that then progress and lead to dementia.
Researchers are actively investigating treatments for dementia, but the best possible solution is to prevent the disease altogether.
When nerve cells die in the brain, we don't have any way of rejuvenating them. So the notion is that if you can intervene really early, then you might be able to prevent that process.
Through their review, the National Academies Committee did not find any interventions that were shown to definitively prevent cognitive decline or dementia. The committee did identify 3 interventions where the evidence was encouraging but inconclusive.
Encouraging but inconclusive evidence, and those words are important. If you engage in these 3 activities, which, by the way, are good for you anyway, then at a minimum, we can say they might help.
One intervention is cognitive training, which includes an array of exercises aimed at enhancing problem-solving, memory, and speed of processing.
Many people assume that cognitive training means computer-based brain games. It's a much more complicated intervention than just sitting at the computer by yourself. There is no evidence, in fact, that the computer-based brain games actually make a difference.
A second intervention is managing high blood pressure in people with hypertension. This could be accomplished through taking blood pressure management medications and sometimes through lifestyle interventions such as diet and exercise. Several studies show a connection between controlling high blood pressure in midlife and reducing risk of dementia later.
Hypertension is an insidious disease. Many people who are hypertensive don't know it. What's important is that you don't try to control it in someone who is 70 for the first time, but it needs to be done in middle age because that's when the brain changes.
A third intervention is being physically active. For example, increasing aerobic exercise and strength training.
That just means doing more than what you currently do. It doesn't mean going out to join a gym or to start doing weightlifting or anything like that. It just means that if you are a person who's pretty sedentary, then you can start by just simply walking.
We know that over short periods of time in clinical trials, physical activity actually appears to show cognitive benefit. And we also know that there are changes in the brain that we can measure, like on magnetic resonance imaging scans.
Managing your blood pressure, physical exercise, it's good for you. Cognitive training won't hurt you, and it looks like it may help you.
To know for sure if these interventions prevent cognitive decline and dementia, more research is needed. The National Academies Committee also recommends a number of ways to improve future studies. One area of focus is enhancing our ability to understand and predict disease progression.
So sometimes we might be using a scan of some sort that tells us about the structure of the brain, that tells us about the proteins in the brain, to try to get a really good prediction of what's going to happen to somebody in 10 years or in 5 years.
At present, a lot of research on cognitive decline and dementia falls short because studies don't follow people for long enough or look at a broad range of the population.
You have to follow people for a very long time in order to see if you've made a real difference. The standard clinical trial for patients with Alzheimer's disease might be 18 months. For people with mild cognitive impairment, might be 3 years. But a lot of these changes take much longer than that to progress. And so we don't have a lot of studies that have followed people with interventions for long periods of time.
We need to go out to the community and get people who don't really come to the hospital, different kinds of occupations, and get them involved in research so that we can see how these interventions work across different populations. We want to be able to inform the public about what they can do to prevent cognitive decline and live long, healthy lives. That's really what we care about.
Learn more and download the full report at nationalacademies.org/dementia.
Because we know that developing dementia is linked to certain risk factors, minimizing those risk factors is important to protect yourself. Remember these very important points in order to keep you and your patients healthy. Increase physical activity to 20 minutes per day every day of the week. Walking is a great activity for all levels of fitness. Eat a well-balanced diet, high in fresh fruits and vegetables and low in red meat and simple sugars. Engage your brain in new activities like word puzzles or problem-solving games. Reduce or eliminate alcohol and other recreational substances. Have a healthy sleep schedule. Get a good night's sleep. Be on the lookout to catch signs and symptoms of dementia early. In summary, we have categorized the differences between brain changes of healthy aging, mild cognitive impairment, and dementia. We have described the natural history of dementia, identified the signs and symptoms, outlined the physical, emotional, and economic impact of dementia. We highlighted the important steps to preventing dementia, and we emphasized the need for further research into prevention and treatment of dementia. This module is the first in a series brought to you from UT Health's Consortium on Aging and is designed to give the community health worker the background and skills you need to help your patients living with dementia or to recognize the signs of dementia in aging patients. In future modules, we will learn more about dementia, including detecting dementia, supporting social and behavioral management of dementia, connecting dementia patients with resources early, identifying and addressing challenges in dementia care, supporting well-being and safety in patients with dementia. Thank you for completing our survey. It will help us to improve our content for future educational modules.